Hi, everyone. Welcome to the Boston Children's Hospital's Spring Allergies webinar. We've got two amazing guests that are going to help you answer lots of questions that you've already pre-submitted. This is a live webinar, but we are recording this, so it'll be on our archive on the Boston Children's Hospital YouTube page for you to share with your friends and family, and certainly come back to this if you have more questions or if you wanted to review any of these very important answers that we have. I'm Brian McKeag, and we've got two great guests that I'm going to ask to introduce themselves. We've got Dr. Suzanne Kellam and Dr. Andy MacGinnitie. Dr. Kellam, do you want to say hello?
Hi, I'm Dr. Suzanne Kellam. I'm a pediatrician at Longwood Pediatrics, and I commonly treat seasonal allergies. Dr. MacGinnitie, you can go ahead.
I'm Andy MacGinnitie. I'm the clinical chief for the Division of Immunology at Boston Children's, and I'm also have an active clinical allergy practice, taking care of mostly kids, but an occasional adult with various allergies.
This is fantastic. I love that we've got a primary care and then a clinical expert on this webinar. And we've gotten lots and lots of pre-submitted questions that we're going to go through. I guess we should start. I mean, it's that time of year again. And we've had a really warm winter and certainly going to have a warm spring and lots of tree pollen. I guess we should just start with what are some of the common spring allergies for kids? I don't know, Dr. Kelman, do you want to start with that?
Sure, yeah. I think almost universally it's tree pollens that causes the spring allergies for kids. And we really think of those coming by April. So we recommend that kids who are known to have spring allergies start thinking about getting their treatment plan in order by St. Patrick's Day so that we can get everything set by the time the tree pollens are around. You want me to go into the symptoms?
Yeah, talk about the symptoms and there's certainly there's a variety of symptoms.
Yeah, so most commonly are nasal symptoms, meaning sneezing, clear runny nose, nasal congestion. That can also cause a postnasal drip and a cough from that. And then you can also get allergic conjunctivitis, which is more of the itchy, watery eyes, as well as just a generalized fatigue from significant allergy symptoms.
And
So,
I'll just
yeah, go
yeah,
ahead,
just
Dr. Ginney. Yep.
jump in and say that I completely agree 100%. In New England, our big seasonal allergen is tree pollen, sort of starting from when the weather warms up till end of May or early June. We do see some grass pollen, sort of late May into June, and then in fall, ragweed is our big allergen. But probably because we live in an area that's wooded, we see really problems with tree allergy. If you go to the Midwest or the West, they have much more problems with grass pollen, probably because it's more plains, and sometimes ragweed.
Dr. MacGinnitie, why don't you talk about the difference? I mean, if I'm a parent of a young kid and I'm thinking, is this an allergy or is this just the cold or influenza?
Yeah. So part of it's time of year. We're now in that overlap time when viruses are still out there and allergies are bad. But if it's, December or January, it's almost certainly a cold. Other things that can help distinguish it is that even though people have traditionally called seasonal allergies hay fever, fever is not typically seen with allergies, and it's not caused by hay, so it's an unusual name, but does indicate sort of how systemically ill people can feel. Secondly, itching of the eyes and nose is typical of allergies and not so typical of viral infections. And third, if you're unsure, often antihistamines will really help with allergic symptoms and not so much with viral infections.
Do you see that a lot in your practice, Dr. Kellam? Just parents coming in saying, I don't know what's going on, but we've got this lots of reaching for the Kleenex.
Yeah, definitely. And I think in practice it can be hard to differentiate. And fever is a really helpful sign that it
Right.
is infection, but a lot of kids get colds without fever. And so sometimes it is based on duration of time. If you're not getting better in the time frame you would expect from a cold, then we start thinking maybe we should be talking about allergies and antihistamines, especially if it's a young kid who doesn't have that known seasonal pattern yet.
And I guess for either of you, how young can a kid get allergies? I mean, and how early can you test for it?
So, and Dr. MacGinnitie can jump in here too, because he probably sees the more rare cases. But traditionally, we're taught that allergies really shouldn't present significantly before the age of 2 because you have to have multiple seasons of exposure to really build up significant symptoms to allergies. So if a kid is under 2, we should really be thinking about other things that might be going on.
Yeah, I concur. Our teaching is also that it's sort of your third pollen season that you start to see symptoms. And just to, as a caveat, for for other allergies, food allergies, for example, that can present in infancy,
Right.
and testing, can be done at any age if indicated. But we typically would not think about seasonal allergies till the kids are over 2 or in their third pollen season.
And Dr. MacGinnitie, what were you had some thoughts about oral allergy syndrome, and
Yeah,
that's
so occasionally we'll see I'll start by saying that there are proteins in fresh fruits and vegetables that cross-react with pollen protein. So often we'll see kids, teenagers, adults who complain that with eating certain fresh fruits and vegetables, say an apple, that they will get an itchy mouth and itchy throat. And sometimes they're worried or, don't really connect this with the pollen, that they've developed all these allergies. And so typically the proteins in the fruit or vegetable, or even sometimes nuts like hazelnut, are very easily broken down or denatured. And so patients will often tell us, if I eat a fresh apple, I get an itchy mouth. But applesauce or apple pie is fine. And that's because the protein in the apple is broken down by the cooking process. For the same reason, it's broken down by the acid in your stomach, which is why the oral allergy syndrome, or what people now call pollen food syndrome, doesn't typically cause anaphylaxis like it would for a patient with typical peanut allergy.
Right.
So mostly we recommend just avoiding foods that bother kids. Usually they don't need more testing. They don't need an EpiPen. Some people find that like peeling an apple or a pear will help, and other people will microwave for 10 or 15 seconds the fruit and then re-chill it. And that seems to also denature or break down the proteins, allowing them to tolerate.
Interesting. Well, so why don't we just move into treatment? I think for some adults, maybe I will be included, I think you think, well, you just suffer through allergies. Like that's just life in this day and age. And I think lots of parents maybe had history with lots of antihistamines that made you drowsy. And I remember, kids at school sleeping and being just kind of either missing school or just being really not very productive. But let's talk about treatment and what can help.
Yeah, so I think there's a lot we can do to help allergy symptoms. And I think that it is something that is commonly misunderstood because it does have a significant quality of life impact on kids. And we have effective treatments and they're very safe. What you are referring to is the difference between newer generation and older generation antihistamines. So something like Benadryl is an older generation antihistamine and it causes drowsiness and it can cause some alterations in mental status. But the newer generation antihistamines, which are things like Zyrtec, Claritin, or Allegra, are much safer and better tolerated. Really, in rare cases they cause a little bit of drowsiness, but not significantly. And those are what we recommend usually for mild allergy symptoms. When kids have significant nasal symptoms associated with their seasonal allergies, then we recommend adding on a nasal steroid because they're very effective and they really do help the most with the nasal congestion that can be really bothersome to kids.
Yeah. And Dr.
Yeah,
MacGinnitie, you would probably see those kids in your clinic.
yeah, I agree 100%. There are various guidelines from different societies about treatment of allergic rhinitis, and really they've all moved from moderate to severe symptoms to recommend a nasal steroid as the first treatment. And if not to bore everyone with sort of the pathophysiology of allergies, but when you have allergies, you have antibodies of a type called IgE that recognize what you're allergic to. So in this case, pollens. The pollens bind the IgE, it activates cells called mast cells that release histamine that cause a lot of the symptoms. So obviously antihistamines help prevent that. But the nasal steroids target an earlier step in the process, sort of preventing inflammation from getting started. And so they're more effective. They do really work best when taken regularly. So I think of if you have mild symptoms and a couple times a year, once or twice a week, you need to take antihistamines, that's fine. But if really you have persistent bothersome symptoms, I would recommend starting a nasal steroid at the start of, or even before the pollen season starts, and continuing it every day or almost every day through the pollen season. That will work much better.
Yeah, I've heard of that term priming. So they say the longer, or I guess the worse the longer the season, the worse the symptoms. So that would align with your suggestion about trying to start before the season starts, the treatment.
Right. If you think about it, on whatever the exact date is, March 15th or April 1st, when the pollen start to hit, your nose is in good shape. There's not a lot of inflammation there. And so you probably don't have a great response. You don't have much of a response to the pollen. If it's now May 15th, and you've been breathing in pollen for a month or more, you have a lot of inflammation in your nose, and even a relatively low pollen count can trigger significant symptoms. So right, I agree 100%. Starting early and using a medicine like the steroid that can really fight the inflammation,
Right.
it will be super helpful.
And Dr. Kellam, we've talked a lot about pollen, but there's also dust and insect. Are you seeing those in your practice?
Yeah, so and that's the difference between a perennial allergy that's all year round versus more
Yeah.
of a seasonal allergy. And one of the ways to know, and this is, I think, something we're going to get into later, but one of the ways to know if they may have more indoor versus environmental allergies is when the symptoms occur and what the pattern of the symptoms is. And if you have a kid who really has nasal congestion and allergic rhinitis symptoms, meaning like the allergic runny nose symptoms, all year round, then you should really be thinking about if there's something inside their home that's triggering their symptoms and it's not just environmental. And
Right.
that's important because the way we treat it is slightly different in terms of exposure avoidance. So when we think of bad spring allergies, the other thing we didn't talk about, but the other treatment we do a lot in primary care is just trigger avoidance. So showering off at the end of the day so you don't go to bed with pollen protein on your skin, wearing a hat and sunglasses if you have significant allergic conjunctivitis symptoms so that your eyes aren't getting triggered, wiping off face and hands when you come in from outside, trying not to have windows open when the pollen counts are really high, those kinds of things. But the trigger avoidance recommendations are different if it's an indoor allergen, because if it's something like dust, then you're thinking about putting a dust protector on your mattress, vacuuming and washing your bedding in hot water once a week, limiting upholstery or limiting like curtaining and
Right.
furniture and those kinds of things that can collect dust.
Well, I guess let's get into it. How do we test? I know there's blood and there's a skin. Dr. MacGinnitie, you want to start with that?
Yeah.
Sure. So I would just add the other thing I would add to the environmental controls, which I thought was great, is that masks are actually super helpful in limiting pollen uptake. So this can be hard in younger kids, but in older kids who are going to be outside, maybe not so active, so they can wear a mask, that can really limit how much pollen gets into the nose and mouth.
Right.
Yeah, so I talked a little bit earlier about how when you have allergies, you make a kind of antibodies called IgE against whatever you're allergic to. And so there are different ways you can test for this. In our clinic, we do skin testing where we have these solutions that contain whatever the allergen is. So, to make dog extract, they shave dogs and purify the proteins from the dogs. They isolate proteins from pollens, et cetera. And then we put it on your forearm or your back and just slightly scratch the skin. And if it gets a red itchy bump, which we call a wheal and flare, then that indicates you're allergic. There's another technology where they actually take your blood and look for these IgE antibodies binding to the proteins in the equivalent of a test tube or Petri dish.
Mhm.
They're both pretty comparable. I think I'll be interested to hear what Dr. Kellam says. I think that not everybody with allergies needs testing. So, right, if for the last 2 or 3 weeks you've had significant allergy symptoms and you know that sort of toward the end of May they go away, I think we're pretty confident that you're allergic to tree pollen and testing isn't necessarily indicated.
Yeah, in primary care, we tend to reserve it if we think it's going to change management. So, like Dr. MacGinnitie said, if it's very clear that it's there's a seasonality to your symptoms, they improve with allergy treatment, then there's really no use in like confirming, yes, it's pollen, because we're pretty sure it's tree pollen. If there is somebody who wants to know really badly if their nasal congestion could be related to their dog or their cat in their house, or they aren't sure if it's a dust allergy or seasonal allergies, and that would actually change management, then I think it's worth it. We can order the blood test as primary care doctors, and that's usually enough to give us a sense of what's going on. Because if it's undetectable, then you have to be sensitized, meaning you have to make some IgE to have allergic symptoms. So if you're not sensitized at all, then that's not what's causing your symptoms.
And
Yeah,
yeah, go ahead.
just almost everybody with an allergy will have a positive test to that allergen. As Dr. Kellam said, it's very sensitive. So if you have negative testing, it effectively rules out the allergy. There is what's called a high false positive rate. And so we will see patients who say, have a weak positive test to dog, but they're around dogs all the time and have no symptoms. And so that's one of the reasons we don't like to test more than we need to.
Is there, and I would think like after a heavy rain, certainly there's not going to be a lot of kind of airborne pollen, and then your kid's outside after that rain, and then you feel like, oh, he or she had a good afternoon. That might, those environmental scenarios might help.
Yeah, I agree. Pollen, rain does wash out the pollen. There's this interesting and rare phenomena called thunderstorm asthma. And so a lot of most patients with allergies to pollens don't get what I'd call lower respiratory or lung symptoms, right? So they don't wheeze, they don't get asthma. There are some exceptions. And the reason for that probably is that the pollen grains are too big to make it all the way down into your lungs. They sort of get lodged in your nose and throat and cause upper respiratory symptoms. But sometimes thunderstorms can actually lead to fracturing of the pollens into smaller particles. And then patients who've never really had asthma, just had allergies, breathe them in and can really have pretty significant asthma exacerbations. This probably occurs, once worldwide every couple years. But when it does, it's pretty noticeable. And the emergency rooms can be overwhelmed with all these patients who've never had asthma symptoms before, who are now wheezing and short of breath.
That is so interesting. I did not know that. And I guess so let's talk about asthma. How do, certainly the testing will help, but are there, co-indications with asthma and allergies, or, how does that help you guys, both of you, in your practices? Helping a parent with that.
I think there is a risk of asthma if you have allergies, especially other, not pollen related, but other like perennial allergic rhinitis. You're at a higher risk, meaning the year-round allergic rhinitis, you're at a higher risk of asthma. But it's really based on symptoms. So it's the difference between upper respiratory tract, meaning like nose and sinus symptoms, versus lower respiratory tract symptoms, wheezing, significant cough that doesn't seem like it's just postnasal drip. And oftentimes it's hard to figure that out on your own. And that's where we come in. We can talk you through the different symptoms and take a good listen to the lungs and see if it seems like there is any lower respiratory tract involvement. But when they do co-occur, treating the allergic symptoms well reduces the asthmatic symptoms. So it is really important to treat the allergic symptoms really well when you have both.
Yeah, I agree. And I would say to some extent they go together, right? So food allergy, eczema, asthma in kids, allergic rhinitis, and now eosinophilic esophagitis are all sort of diseases under the same rubric of atopic, meaning that allergies play a role. And then for certain indoor allergens, dust mites in particular, and being exposed to pets, if you're allergic to them, that definitely plays a role in causing inflammation in the lungs and worsening asthma symptoms. But just sort of by chance, even if you're pollen allergic, even if the pollen doesn't trigger your asthma, you're at increased risk of asthma just by being an allergic person.
Right. I guess for folks just joining, maybe we could just review. We talked a little bit about it, but let's be real specific. What can a parent do to reduce those symptoms for a kid? We talked a little bit about masking, maybe sunglasses, certainly washing, taking a shower before bed, or certainly washing hands before coming in from outside. Let's just review those one more time.
Yeah, so I mean, you touched on most of them, but wearing a hat with a brim and sunglasses, especially if you get eye symptoms, masking if you're able to, and then washing hands and face when you come in, and shower and changing your clothes when you come in from a long period of time outside, and then taking a quick shower at night so that pollen doesn't sit on your skin all night long are sort of the biggest pollen avoidance things. I don't know if you have anything else to add.
Yeah, I think of it as you get the pollen on your skin and your hair, and then it's in your bed and you're breathing in it all night. So anything
Right.
you can do to sort of separate and clean. Other things, I think that air conditioning, if you have it, either central or window units, is very effective in filtering out pollen. So we recommend patients use it even if they don't really need it for the cooling. And then, just making sure to keep things like sports equipment that's used outside out of the bedroom, because that can be another source of pollen making it into the bedroom.
Yeah, and a kid spends a lot of time in his or her bedroom, so maybe that would be the spot for the air conditioner, just to keep running for for that filtering. Interesting. And again, for folks coming in a little bit late, what's the earliest that you would want to start testing? And again, to your question about a parent just kind of overwhelmed with a kid with this runny nose, where do they, how can they work with you guys, either at primary care or the clinic, to know as soon as possible what we're dealing with? What's the right age?
So it's not something that I would test for without clinical symptoms for the reasons that Dr. MacGinnitie touched
Right.
on, in that like you can get positive testing that doesn't really tell us anything if you're not having symptoms. So it's rare under age 2, as we had talked about.
Yeah.
And so I definitely wouldn't think of that as the cause under age 2, except in rare circumstances. But I would not test like prophylactically for allergies.
Makes sense.
Yeah, and I would say starting, sort of with that third pollen season. So after age 2, if people are symptomatic, it's reasonable to do a treatment trial, right? So often in the younger kids, we do antihistamines because they're easier to get kids to take. But nasal steroids can also be used, as well as eye drops if patients have eye symptoms. So, all these things are over the counter now. So I think many patients try them even without talking to their primary care doctor.
Right.
Certainly almost everyone has tried them by the time they make it to me. So I think it's reasonable to try, reasonable to talk to your pediatrician or primary care doctor about what the first steps are in treatment.
Great. Well, this is great. So we're just going to move on to our questions. We got lots of pre-submitted questions, and we'll just go down the list, and you guys can answer these. I think this is a great one. At what age? No, we did that one. In what situations are allergy shots recommended for children?
Yeah, so I think I can take this one.
Yeah.
So just to review, right? I think of allergies as your immune system seeing pollens or other antigens as dangerous. So you might sneeze or cough or wheeze or whatever it is to try to have your eyes water to protect you from these allergens, but they're not really dangerous, right? And people who don't have allergies, don't have these symptoms. And so allergen immunotherapy, which is the fancy word for allergy shots, are a way to try to sort of desensitize your immune system or teach it not to be allergic again. It's a series of shots building up from a very low concentration. In our clinic, it takes 6 to 8 months of coming weekly to get up to the highest dose. And then we recommend treatment monthly for 3 to 5 years after. So it's a huge commitment.
Wow.
This used to be done more before we had effective therapies like non-sedating antihistamines and nasal steroids. So really, I think allergen immunotherapy or allergy shots is reserved for the kids who are just miserable despite maximal medical therapy, or for some reason can't tolerate medical therapy. And then I'll just point out that for certain allergens, including dust mite, ragweed, and grass pollen, but unfortunately not tree pollen, there's what's called sublingual immunotherapy, which is drops that are under the tongue. The first dose has to be in a physician's office, but after that, they can be given at home. Unfortunately, in New England, tree pollen is our big player, and we don't have it for that. And then for dust mite, the age limit is 18, so it's not really helpful in kids, but there is that possibility out there for the person who grass pollen, which is sort of late spring, early summer, or ragweed, which is a fall pollen, really make them miserable.
Yeah. Dr. Kellam, any other thoughts on that?
No, I agree. I think that it is just a huge commitment for families, and especially for teenagers. If they're going to be going away to college within that time
Yeah.
frame, then it really doesn't make sense. It's the kind of thing you do have to commit to finishing. So we reserve it for the patients that Dr. MacGinnitie mentioned.
Yeah.
Yeah,
I have
and
a question. Go ahead.
yeah, no, I just tell people this is not like trying a new nasal spray that you try 3 weeks and you see if it helps. It's not till you get through that 6 to 8 to the higher doses, sort of 6 months or so in, that you start to see a benefit. So you really gotta be committed, and the shots have to be given in a physician's office, usually our office. You gotta be watched half an hour after. So it's, it's easy to think, oh, great, I'll do this, and then just never be able to find the time.
Yeah. For those over-the-counter medications, is it better in the morning or at night? Or does it depend?
Yeah, I think if you theoretically they should work for 24 hours, but I do think it's better to take them in the morning so that you're getting the peak effect during the day. And as we had talked about, they really shouldn't be sedating at the usual doses that we recommend them.
Yeah, I agree. I think there's a little bit of data that none of them are truly 24 hours, with the possible exception of levocetirizine, which is Zysol. So some patients have found that splitting up doses for kids, if they take a liquid, is helpful. But I agree that usually the morning is the best. And then I will say that there's no head-to-head studies, but the three big non-sedating antihistamines are loratadine, which was Claritin, it's the brand name, fexofenadine, which was Allegra, and then cetirizine, which was Zyrtec. And among allergists who have allergies, people feel that cetirizine is the strongest but has the most side effects. Fexofenadine is the middle, and loratadine is the least effective but has the has the least side effects. Although both are close, right? So we probably get 90% of the benefit with loratadine that you would with cetirizine. And then I have many patients who one or another seems to cause problems. So if you try one and you get some side effects, that doesn't mean you can't take any antihistamine. Maybe you should try one of the others as an alternative.
That's great. Well, that leads into the next. Oh, go ahead. Go ahead.
Oh, just one more thing. Dr. MacGinnitie, isn't it for kids under 12, Allegra has to be twice daily too? So
Yes,
that's something else to keep in mind, is that that's the only one that has to be twice daily.
correct.
Well, that leads to this question about, are there long-term health effects to Zyrtec, Allegra, Claritin, all of these over the counter?
So I think the answer for the antihistamines is really no. There's nothing that we know of. It can have some dry mouth at like usual doses, and that's really the biggest side effect. I think I don't know if we should talk about nasal steroids now.
There was a study, so about 10 or 15 years ago, there was this hypothesis that if you took kids with allergies who we know are at risk of developing asthma, and you gave them Zyrtec round the clock for a couple years, like every day, that it would prevent development of asthma. And so they did this study, and it turned out it didn't work. It didn't prevent development of asthma. But as part of the study, they compared kids who got the cetirizine, the Zyrtec, and the placebo for things like how much they slept, how they did in school, what their attention was like, and there was no difference. And so that really, I think, has given us a lot of confidence that these medicines are safe to use regularly.
Great. And then what was your question, Dr.
Oh,
Kellam?
just the other piece of it is the nasal steroids. So something
Right.
like Flonase. And the theoretical risk with that is that there would be some systemic absorption of the steroid, and that it could affect either things like your adrenal axis or growth. You might know this better than I do, Dr. MacGinnitie, but there was a big study that showed that the effects on growth are pretty negligible from nasal steroid use. It was pretty much nothing to maybe even up to like 1/4 of a centimeter per year. So the effects on growth are pretty minimal to non-existent in usual doses. They also used very high doses in the study.
Yeah, I agree. The two nasal steroids that are over the counter and that we use a lot are fluticasone, which is Flonase, mometasone, which is Nasonex, and then their generic equivalents. And both of those have really minimal absorption through the nasal cavity. So I agree. The one sort of class of patients we worry about is not those who use nasal steroids alone, but those who have asthma, use inhaled steroids, have eczema, use topical steroids, and use nasal steroids. And there's a little bit of concern that the sort of additive use of all those may be detrimental. And so if you or your kid is in that situation, I would recommend talking to your doctor about it. You still may need to use them, but that raises our concern more than just the nasal steroids alone.
Well, so that leads us to, what about natural remedies? I've heard about local honey, purchasing and eating local honey that would help. But I'm sure a lot of parents are more, would be interested in natural remedies.
I don't really know of any effective natural remedies. I don't know if you have any
Yeah,
thoughts.
so saltwater sprays can help some kids with mild symptoms. So I don't know if that's really natural, but it's not a medicine. Local honey, I think you're welcome to try. The data is not so strong that it's helpful, but it's unlikely to be harmful and probably delicious. So I wouldn't shy away from it, but I wouldn't use that, for somebody with severe allergies who's really miserable.
Great. Here's another question that came in. Allergies versus colds versus long-term bacterial infection, bronchitis. When should we urge our providers to prescribe antibiotics for our children, especially with the rise of the fear of drug resistance? That's certainly a concern. And when a cough is wet or the duration of symptoms more important?
So, I would say this is something we see a lot in primary care, and allergic symptoms can set you up to get a secondary bacterial sinus infection because, similar to any virus, you can have really bad congestion and then some gunk can build up, it can get infected, but you really should see a secondary fever at that point, or what we would call really purulent nasal discharge, so like constant green gunk coming out.
Yeah.
If that's not the case, then it's probably not bacterial and doesn't need antibiotics. There's a lot of evidence that bronchitis is almost never bacterial. And so we very rarely prescribe antibiotics for bronchitis, which is more of like an upper airway infection. And you can have a pretty bad cough from allergic symptoms because of the postnasal drip. So I would treat the allergic symptoms appropriately first and then see what happens if there's no fever or other big indicators of an infection.
Yeah, I agree. When I've seen, definitely patients with allergies are predisposed, especially to sinusitis, but usually it's a significant worsening of symptoms, and they'll tell you this is very different than my typical allergy symptoms, which are, controlled either well or to some extent with allergy medicines.
How often do you see kids with the eye irritation versus the nose and throat irritation? Or is that just case by case?
We see quite a bit of allergic conjunctivitis
Yeah.
in primary care, and it often is the most bothersome symptom to the people who have it. And the eyes can be quite swollen, red, irritated. And we do also have antihistamine eye drops available over the counter to treat that specifically. So we recommend that in patients frequently who have eye symptoms. But again, that always becomes a question of when it's infectious versus allergic, but it's really itchy. And then it gets swollen because kids are constantly rubbing it. That's a good indicator that it's allergic and not infectious.
Makes sense.
Yeah, I think that the calls we get from people who are miserable are often the eyes. And then
Right.
I just, in addition to the eye drops, the nasal steroids really do help with eye symptoms. Probably because the inflammation in the nose spreads to the eye. And so the eye drops help with the eyes, the nasal sprays help with the nose, and overall it lowers the overall rate of inflammation. And that can really be helpful. So if you're really suffering, the eye drops aren't helping, starting a nasal steroid can really help.
Great. Well, eyes and throat, and we've got a question submitted. My daughter often breaks into hives in the spring, and we don't have a known cause. She gets itchy and very uncomfortable. At what point do you recommend we pursue testing? So hives.
I mean, I don't know if you have any thoughts about this one specifically, Dr. MacGinnitie, but I think I would treat first the same way and see if it helps. And if it doesn't help, then I think that's when I would consider sending to a specialist or getting further testing.
Yeah, it's interesting. I don't think of hives as being a typical sign of environmental allergies. with the exception of sometimes, people with horrible eye symptoms get some few hives around their face where the pollen actually touches them. That said, when people have, so the fancy doctor word for hives is urticaria. And when they have what we call idiopathic urticaria, where idiopathic means the cause isn't known, we typically don't test for allergies. We don't do a lot of testing. We treat with antihistamines, the same one, cetirizine, loratadine that we use. And if that controls it, we just treat with that. So I think that treatment would come before testing in this case.
Makes sense. We have another question submitted. For kids who can't take antihistamines due to ADHD and anxiety, what are other options? It sounds like this son or daughter has frequent nosebleeds too.
I think those are two separate questions. The first is that with ADHD and anxiety, and this might be going back to the difference between the newer generation and older generation antihistamines. The newer generation antihistamines, which are the things like the three that Dr. MacGinnitie mentioned, cetirizine, loratadine, and Allegra, those are safe to use with anxiety and ADHD, and there really shouldn't be a significant cross-reactivity there. I probably would avoid Benadryl, but that would be a discussion with your doctor. And if your kid is not tolerating those for whatever reason, I would discuss with your doctor. And then Flonase, which is a nasal steroid, can cause nosebleeds if you are prone to them. One thing that helps is avoiding the nasal septum, which is the middle of the nose, because that's the thinnest part that can most tend to bleed when you're doing it. And using Vaseline can help too, but that is one of the potential side effects of a nasal steroid.
Yeah, and I agree 100%. So we tell kids to aim to the tip of the ear on that side so that they're aimed away from the septum where you do see nosebleeds. And then I have noticed that a lot of kids will really want to jam the device up their nose, and it has a spray. So we tell them just right at the entrance or a quarter inch in. You don't need to get the nasal spray, way up there. It'll shoot up there. So those can be helpful in avoiding nosebleeds. Some kids who dry out, we also find that adding a nasal saline spray, other times of the day can help with the nosebleeds.
I wonder with all the COVID testing, if kids are more comfortable or less comfortable, or to your point, Dr. MacGinnitie, using the COVID test similar to treatment for the nosebleeds.
And then there's a formulation that's only proprietary or trade called Flonase Sensimus. That's more of a mist than a spray. And I have had many kids or teenagers who find it more tolerable just because it feels better, but also maybe less prone to cause nosebleeds. So that's another option.
Makes sense.
Yeah, we do Sensimist a lot in the young kids because it's the only one that they'll be okay with.
Makes sense. We also have a question that was submitted about someone who has an allergy test that's positive to common mold with an office allergy test. Should we try to identify the source, such as an air conditioner or a basement? And then we, certainly common outside with rotting leaves, et cetera. How much can we try to avoid this, and how much is it just environmental?
I think one thing that's helpful with molds is a dehumidifier, because you want to make sure that the apartment or house is not too humid, because that's when molds are most likely to grow.
Yep.
And then you can see if you can identify any source in your house, but that's one thing to consider.
Yeah, and I would just say, I think the first part of this question, as I interpret it, is if I have, a test that shows I'm highly allergic to something, does that necessarily mean I have an ongoing exposure to that? And I think the answer to that is no. So I know it's not the same disease, but we have patients who reacted to peanut when they were babies, have not been exposed to any peanut in 20 years, and still have very positive testing. So the fact that you're positive to mold means that you were exposed at some point in your life, but doesn't necessarily mean that you have to go searching for where the mold is that is causing this, because you may have this allergy without ongoing exposure.
Interesting. Something we haven't talked about is genetics, and is this question is great. I have suffered lifelong allergies, grass, tree, mold, animals, and it appears though my 7-year-old son is following in my footsteps, given his symptoms. Knowing that the testing is not pleasant, at what age does testing make sense if the parent has allergies?
I think the first part of this is the genetic component to allergies, which is still not completely understood, but the risk of being atopic, which is having all of the diseases that Dr. MacGinnitie mentioned earlier. So, food allergies, asthma, allergic seasonal allergies, environmental allergies, eosinophilic esophagitis. The tendency to be atopic is inherited. And if you have a parent who is atopic, meaning has that constellation of diseases, eczema is the other one, then you are more like you are at a higher risk of having atopic conditions as well. But to my knowledge, and Dr. MacGinnitie can jump in, the specific allergies aren't inherited. So, like, just because you have pollen allergy does not necessarily mean your child is going to have pollen allergy.
Yeah, I think that's right. Probably there is some, there are like asthma specific risk genes that we know. But I agree. It doesn't mean that your kid necessarily is going to have it or they need to be treated differently, but you should be aware of it. I'll just say the one thing that, we recommend to sort of prevent allergic disease is avoiding cigarette smoke exposure in kids,
Right.
which will decrease their risk of asthma. The higher the risk is genetically, the more effective that'll be. But obviously we would recommend that, avoiding that exposure for all kids. And that's really like in the house or somewhere they're, reasonably. Occasionally I get parents who worry, sometimes they walk down the street and they pass someone who's smoking. If that happens, once a week, that's not a significant secondhand smoke exposure.
Right. Thank you.
And we'll get
Go
people
ahead.
who are like, but I always smoke outside. And it's really important to tell those people they also need to change their clothes because the cigarette smoke lives on their clothes and then comes into the house.
And not to smoke in their cars if they drive, because those, it's a confined space. You really can get high levels of the byproduct.
Great. We have our last submitted questions. Question is, in teenage years, do over-the-counter medications like Zyrtec become less effective? And if so, what should teenagers do?
They don't become less effective, but you might need to look at what dose you're doing and talk to your physician about the dosing of the medications that you're using. And like Dr. MacGinnitie said, if one of the three is not working as well, you can always try a different one.
Right.
Yeah, and I think I'm pretty sure that as teenagers are less regular about using their medicines when their parents aren't reminding them like they when they're 6 or 7. So that's part of it. Allergies tend to get, sort of worse over time and then maybe better. So often we do see more severe symptoms in teenagers. And then as we talked about, other medicines like nasal steroids, are a good second line option or first line for patients with moderate to severe symptoms.
Wonderful. Well, we were out of time. Thank you so much. This has been the Boston Children's Hospital Spring Allergies webinar. Thank you, Dr. MacGinnitie and Dr. Kellam. Any final thoughts for either of you, for parents?
No, but just talk to your pediatrician if you are concerned or have more questions. This is something we see very frequently in Boston. And the one other thing I'll say is I also hear a lot, we just moved to Boston from somewhere else, and all of a sudden I'm having so many allergic symptoms, and that is definitely possible. So if you are new to the area and you're finding that your symptoms are very different, just talk to your pediatrician and they can get you started on a good plan.
Great advice.
Yeah, I agree with all this. And then if you're suffering or your kid is suffering now, I would say hang in there. We're in the sort of height of the pollen season. In another month or so, maybe 6 weeks, people will probably be doing better.
Fantastic. Well, thank you both so much for joining. You gave some great advice and great information. And again, this is a live recording, but this will be archived on our YouTube page for you to share with friends and family. But thank you so much for joining us.
Thank you.
Take care.